Hello and welcome back to the Addiction Medicine Podcast from the Governor's Institute. I'm today's host, Cheryl Viracola, Director of Practice Advancement with the North Carolina Association of Pharmacists. In this episode, we're talking about something that's changing how people get access to medication for OUD, or opioid use disorder, also known as MOUD, and how pharmacists and providers are teaming up in a really powerful way. These partnerships are helping to bring treatment into more communities, especially in places that might not have had access before. We're talking about collaborative care, and we're going to dive into how it works and why it matters. I'm joined today by two fantastic guests, Dr. Charles McCormick, Deputy Chief Medical Officer at Alliance Health, and Dr. Vera Reinstein, a clinical pharmacist at Alliance Health. You're both deeply involved in implementing these models and supporting others to do the same, and we're so happy to have you with us today. Let's start by laying some of the groundwork. When we say collaborative care model, in the context of treating opiate use disorder, what are we really talking about? And I'm gonna turn to Vera for this one.
Sure. So recent changes, about 2022, in pharmacy scope of practice statutes allow community pharmacists, those that are specially trained and authorized, to administer LAIs. This pharmacy scope change is an opportunity for collaboration between these pharmacists and community providers who may prescribe LAI MOUD. These pharmacies, in collaboration with the prescriber, can jointly manage the administration and monitoring of these FDA-approved long-acting MOUD injections. After the provider and patient decide to trial a long-acting injection, a prescription is written and sent to the pharmacy with the dosage and frequency directions along with the specification pharmacy to administer and manage. This enables the pharmacy to meet with the patient, discuss the treatment plan, and begin the injection series and share the clinical documentation with the prescribing practice. In this collaboration, the pharmacy tracks the patients, plans the timing of injections, makes injection appointments, makes follow-up calls for patients who do not present at the appointment time, and informs the practice within 48 hours for psychotropic LAIs or within 72 hours for non-psychotropic LAIs of an injection administration, or if an injection was missed, as well as any follow-up actions and next steps.
So what are some of the biggest benefits that we see with this model?
I think the biggest one is improving access to MOUD in the patient's local community, also especially in rural communities where providers may not be available for injection administration. One of the key benefits is that this model allows everyone involved to work at the top of their license. So that's for providers to diagnose and prescribe buprenorphine, and pharmacies to order, administer, and coordinate injection appointments and provide feedback to providers with each injection or missed appointment. Pharmacies have medication adherence programs, and they can track patients for refills, and so this model really takes advantage of that. Pharmacy LAI administration can also help support same-day inductions for medications like LAI buprenorphine. In the provider LAI administration model, the turnaround time for a patient to see a prescriber who sends the prescription to the pharmacy and then needs the product delivered back to the prescriber's office, it's not very realistic for that all to happen in the same visit or the same day, except in the rare circumstance where you've got a pharmacy that's co-located with the provider, but it's not too common. With this model, providers and patients are able to take advantage of same-day induction for medication. Now, one thing it's important to note for listeners here that this is a collaborative model, and it does not happen without the prescriber requesting this collaboration. The prescriber remains in the driver's seat as to whether medications are administered by a pharmacist. Again, this request is done by the prescriber indicating on the LAI buprenorphine electric prescription comment line that it should be pharmacy to administer. And again, then the pharmacy contacts the patient, manages the administration, reports back to the provider within 48 hours, whether it was given or if there was an issue like a no-show. If the medication is not going to be administered by the pharmacy, then the pharmacy has to deliver it to the prescriber's office for administration. And that requirement for delivery is there because LAI buprenorphine products can never be dispensed directly to a patient for safety reasons.
Great, thank you. So I'm going to shift gears for just a second and talk a little bit about a new resource that's recently become available for pharmacists. I've heard it not only promotes collaborative care, but it also strengthens the pharmacist's role in improving access to buprenorphine. Vera, can you tell us a little bit more about that?
Sure. So the Pharmacy Access to Resources and Medications for Opioid Use Disorder, or PharmOUD, guideline is a joint consensus practice guideline from the National Association of Boards of Pharmacy, as well as the National Community Pharmacists Association. It's also been endorsed by a number of professional organizations, including the American Society of Addiction Medicine, the American Pharmacy Association, the American Society of Health System Pharmacists, and the American Association of Psychiatric Pharmacists. This guidance for pharmacists directly addresses important regulatory aspects related to buprenorphine care that directly impact pharmacy practice. This guidance was set up exactly and only for pharmacists, and this can help pharmacists make dispensing decisions that optimize the quality of care for folks prescribed buprenorphine. This guidance, importantly, also supports telehealth, access to the buprenorphine monoproduct, and also addresses stigma. Listeners can find this guideline at the National Boards of Pharmacy website, and by typing in pharm-oud-guidance.pdf into their web browser.
Thank you, Vera. You all shared, I know, some great data about your LAI project's effectiveness at the Governor's Institute Addiction Medicine Conference that was held this past spring in Asheville, North Carolina. I'm wondering, can you talk just a little bit about the major findings from your pilot?
Absolutely. In general, we know that patients who need MOUD do better with the use of LAI buprenorphine, and that means staying in treatment longer, being off other non-prescribed drugs. There was a great recent meta-analysis of 18 studies that showed that in comparative trials, LAI bup was superior to placebo and superior or non-inferior to treatment as usual. LAI buprenorphine is positively associated with improvements in abstinence rates and patient-centered outcomes. We know it's an effective treatment for OUD with advantages over other forms of treatment like transmucosal buprenorphine. We know that steady-state levels in serum stay and remain high, and that can mean the difference for some people between meeting their goals, including abstinence, and being at higher risk of a relapse. Patients reported high levels of medication satisfaction, and there were no significant safety concerns in this meta-analysis or the many trials that led up to it. We're also aware of some of the difficulties encountered by patients and providers in accessing transmucosal buprenorphine. Think about your patients who have unstable domicile, for example, or difficulty or who may be experiencing a lot of changes in their residence from, let's say, hospital to long-term care to substance abuse treatment facility to unstable housing and back again. If you're receiving an intermittent long-acting injection, your chances of having that medication in your bloodstream at a level that helps keep you abstinent and reach your goals, that's going to be higher for a lot of folks with LAI bup compared to transmucosal formulations, and that's the kind of access that we seek to expand.
And on the pharmacy side in particular, the LAI buprenorphine products are not followed on the source report as it is never in the patient's possession. So this makes it a lot less problematic for pharmacists to maintain this in their inventory without concerns of triggering a DEA audit. Also, pharmacies are brick and mortar sites, and in some cases, providers may switch office locations to meet patient care needs, and the provider office may not be available when the patient's injection is due, or staff may be out sick. So the pharmacy, which is typically open 6 to 7 days a week and often with extended evening hours, may be a more accessible option for patients to receive their LAI administration without having to get off work or having to arrange transportation to a distant location for administration. And that's not to mention even with the rise of telehealth. Their provider may be far, far away.
Great, thank you. And again, that data and the information was shared during a presentation at the Governor's Institute Addiction Medicine Conference in Asheville. And you can watch a replay of the presentation on the Governor's Institute Addiction Medicine training site. You can find that at addiction-medicine.org. Again, for our audience, that's addiction-medicine.org. Let's shift. Let's talk a little bit about implementation. So let's say I'm a provider out there and I want to build a relationship with a local pharmacy to actually start doing perhaps LAI administration. What should I do first?
Well, we're actively directing providers to something called the NC Pharmacy Locator website, which was developed by a team led by none other than our moderator, Dr. Cheryl Viracola. Cheryl, would you be so kind as to elaborate on this, what this platform offers?
Absolutely. Thank you, Vera. Yes, the North Carolina Pharmacy Locator website is really a fantastic tool for providers that want to collaborate and to help connect their patients with community pharmacies that offer different types of specialty services across our state. There's actually 18 different specialty services that are built into the Locator website, so it's incredibly versatile. Now, let's say you are a provider out there. You're looking for a pharmacy in your area that offers long-acting injectable administration. You would simply enter the website's address, which is fairly simple. You can just put in ncpharmacyfinder.com into any web browser. And once you reach the home page, you can simply click on Browse Pharmacies. What this will do is it will open up a filter that you can use on your left-hand side to narrow your search down to the location that you're looking for, the city, the county, the zip code. You can also filter by specific services that you're looking for. Once you've applied those filters, then the site actually will create a personalized list of pharmacies that match your search criteria. In other words, you'll see the names and the locations of those pharmacies, the contact details, the hours of operation. You'll also get a full list of the services that each pharmacy provides, in addition to the ones that you are actually filtering on. It even provides a Google directions. It's linked to or integrated with Google Maps, so it can help you to, and or your patient, to get to that particular pharmacy with ease. And it really takes the guesswork out of finding the right pharmacy to meet your patient's needs. So having said that, moving on, what are some common barriers that pharmacies face when it comes to starting up a service like LAI administration?
So some common barriers for pharmacy include, first and foremost, lack of awareness that pharmacies can even order long-acting injectable buprenorphine products, as initially they were restricted to a few specialty pharmacies. Then even if they are aware that they can order it, they may not be aware that pharmacists in North Carolina are able to administer long-acting injectable medications. And then even if they're aware of the authority to administer, they may be unaware that this authority includes long-acting injectable buprenorphine products specifically. And so then pharmacies, even if they're aware that they can administer LAI bup, they may not be aware that they can bill North Carolina Medicaid an injection administration fee of $17.36. And then they may know that they can bill it, but it's also now there's 9 different Medicaid health plans in North Carolina, and they may be unaware of how they actually bill each specific plan. Dr. Mina Wolf, when at UNC, found reimbursement was a major barrier to pharmacy LAI administration. The reimbursement barriers include the product as well as injection administration. Regarding product reimbursement, many pharmacies are sharing with us they're actually under-reimbursed for these expensive LAIs. An LAI may cost $2,000 to $3,000, and a pharmacy may lose money or make only a small amount on that product. In no other business, and pharmacy healthcare is a business, are companies expected to lose money or barely profit. It's not sustainable for these pharmacies, and the cost of these meds in their inventory can negatively impact cash flow. One of our grant team's goals is to have this administration fee reimbursement adjusted sustainably. And along those lines, our group found that it took about 30 minutes for an LAI psychotropic administration service in the pharmacy. And the reimbursement they receive is $17.36, which pharmacies will tell you does not cover the time. Again, our team is lobbying Medicaid for an increased reimbursement based on our findings and the need for additional LAI administration resources in our communities in order to expand access to care. Excitingly, recently passed North Carolina legislation should require all plans to reimburse pharmacies for LAI administration in the near future. If pharmacies offer an LAI pharmacy service, currently Medicaid is the only payer offering reimbursement. So a pharmacy offering this service would be doing so for no payment for many of their other patients that are covered by North Carolina Medicaid plans. The recent passage of House Bill 67 makes for an exciting time as other payers will soon be required to reimburse for services that North Carolina Medicaid supports, and at that same time making our team's efforts to improve the reimbursement rate for LAI administration all the more critical. Another barrier is that pharmacies need to register for two separate REMS, which are Risk Evaluation and Mitigation Strategy, programs for each, one program for each LAI buprenorphine product. This REMS program registration includes developing store policy and procedures in order to prevent the accidental dispensing directly to patients. Pharmacies are not able to order the LAI buprenorphine products until after they are REMS registered to dispense. In fact, the product doesn't even appear in their ordering sites. Pharmacies need specialized contracts to purchase these products in order to be reimbursed above acquisition cost, and many pharmacies are unaware of these or are not sure of their access to these contracts. This is a very common barrier for all LAI medications and is especially problematic for expensive LAIs that increase cash flow requirements that, frankly, many smaller pharmacies are not able or willing to undertake. Pharmacies dispensing LAI buprenorphine and offering injection administration will still typically be dispensing LAI buprenorphine products for the prescriber's office. And as we said, since it can't be dispensed directly to the patient, this will require the pharmacy to have to deliver the medication. Sublocade, in particular, requires cold pack delivery. The delivery fees are typically not reimbursed by insurers, with the exception of North Carolina Medicaid, which does allow the billing of a $3 delivery fee. Pharmacies report their delivery expenses typically start at about $9 per prescription and can be more than triple that for cold pack delivery required for Sublocade.
One other barrier we discovered was that of improving provider awareness of the possibilities of this collaborative model and how it would work. So our team has spent some time and effort, and will continue to do so, in the area of academic detailing about the collaborative model. So this entails similar processes to what we are talking about today. As the psychiatrist on the grant team, I'm working on an academic detailing effort in local health systems, community psychiatric and addiction medicine groups, and other stakeholders to try to increase awareness of the potential for collaboration between community pharmacists and community psychiatrists in increasing the use of LAIs in the populations that they're already co-managing. Already in the health system domain, making clinical administration aware of the importance of initiating LAIs in the ER and in inpatient units for the right patients. In particular, for those who are on LAIs who, once are initiated, don't require overlap with an oral medication. So again, raising awareness of this patient group is one of the first steps here. Covering the operational aspects of pharmaceutical company-sponsored first-dose replacement programs, which comes at no cost to the healthcare system, that's another component of academic detailing to healthcare systems. So just making sure that the places where people are actually seen, which is not always just stable in an outpatient setting, but in emergency rooms, inpatient units. Again, making sure that those providers of healthcare, like healthcare systems, understand the availability and the importance and the power of being able to use this model. That's one of the key thrusts of our team right now, getting that awareness up. So in our academic detailing, we're also talking about the benefits to patients. As we talked about before, increased access to needed care is the big one there. There's benefits to providers, such as decreased administrative burden in managing long-acting injectable medications and letting the pharmacists do what they are already good at in that regard. And there's benefits to payers, too. So obviously patients who get the medications they need and get to remission quickly and stay there are well longer. They stay out of the healthcare system unnecessarily, and that means the total cost of healthcare is stable. So there's benefits to all parties involved. Some examples of the detailing we're doing include doing talks at provider meetings, poster presentations, disseminating briefs describing the model and its benefits, getting articles into journals describing the work, and using the internet to get information out regarding the model. It's a multifaceted approach that we trust with enough ongoing time and effort, we'll get the job done, we'll get the word out.
Well, it definitely sounds like there are a lot of moving parts to consider. So what would you say are some practical ways to overcome some of those common barriers to getting an LAI service up and running?
Sure. I think one of the first is education by peer pharmacies who are already administering LAI buprenorphine. That's one of the most, that may be the most effective route. So when pharmacists talk to pharmacists about what their experience has been and how it works. Another avenue is support from both the North Carolina Association of Pharmacists and from your local North Carolina Medicaid tailored plan. As folks probably know, there's 4, depending on what part of the state you live in, via Trillium Partners and Alliance. And the NCAP and your local North Carolina Medicaid tailored plan can assist with education and in some cases offer other supports too. Also, at the county level, there's opioid settlement funding, which can potentially be spent to incentivize local pharmacies to get into this space and help offset some of the startup costs associated with starting a service like this. Your tailored plan, again, via Trillium Partners or Alliance, they may also have funding for uninsured members of the health plan to help increase patient volume. That's going to help reduce costs and make the program more feasible for community pharmacies. And at the end of the day, if a pharmacy hits what appears to be an insurmountable barrier, they can contact the NCAP. Jerry McKee has been instrumental there in helping to explain and knock down barriers for his pharmacy colleagues around the state. And again, a pharmacy can also contact their tailored plan pharmacy director for further assistance. Every tailored plan has a pharmacy program, and the pharmacists who work there are going to be familiar with how to help overcome some barriers.
Well, what if a provider feels stuck? Maybe they can't find a willing pharmacy or they perhaps hit a logistic wall. What should they or who should they contact?
Sure. Providers can identify their community pharmacy partners in the space through ncpharmacyfinder.com. Like we heard about before, you can filter by service, in this case LAI buprenorphine, to find local pharmacy partners who are already offering LAI bup. And if you don't see a local pharmacy who's offering LAI buprenorphine administration, then you might consider starting with those who are administering other LAIs, like LAI antipsychotics. Those are going to be pharmacies that are good candidates to reach out to and see if they are willing to expand into the LAI buprenorphine space. If a provider hits what appears to be a barrier they can't get over, again, they can contact the North Carolina Association of Pharmacists or their tailored plan pharmacy director for more help.
Thank you, Charlie. So this conversation shows just how much potential there is when pharmacists and providers start teaming up. It's not just about convenience, it's about getting more people the care they need when and where they need it. If you're a provider, start by reaching out to a local pharmacy. Share this podcast. Look up the PharmOUD guidance. You can find it on the website again at alliancehealthplan.org/programs. It's under the Pharmacy Resource tab. Also remember, you don't have to figure this out all alone. There's a growing network ready to help and support you. I'd like to thank both of you for joining us today, and thanks to all of you for listening to the Addiction Medicine Podcast from the Governor's Institute. Until next time, take care.